I'd like to thank you for the organisers for putting on such a great event and for inviting me today. As it was just said, my name's Simon Russell. I'm the Trauma and Injury Intelligence Group Project Lead at the Centre for Public Health within Liverpool John Moores University. I'm going to discuss the role of TIIG data in reducing alcohol-related hospital admissions. And when I was first approached, it was to discuss the Cardiff Model, which was quite innovative. And there are lots of similarities between the Cardiff Model and the TIIG model, but there are some differences as well, which I'm going to discuss. So today I'm just going to give a brief overview of the Cardiff Model, an overview of the TIIG model, and then I'm just going to focus on a couple of hospitals because they are particular examples of good practice in what we do. So the Cardiff Model, it kind of started in 1996 when it was noticed that there was such a high demand on emergency departments due to alcohol-related harm and unreported violence. Estimated that about 65% of violence was unreported to the police. That's something I'll come back to in just a minute. It was fully implemented in 2001 and is basically a system for sharing data between EDs and community partners who might then initiate a response, an appropriate response. The objective is to prevent violence and reduce the burdens on emergency services. In 2007, the Cardiff Model, Effective NHS Contributions to Violence Prevention, was published, and it outlined that the essential components of this model were data collection systems within EDs, which were preferably electronic, the capacity to anonymise and share ED data, which is absolutely crucial in terms of confidentiality. They also recommended a data analyst to integrate and compile the data, as well as an NHS ED consultant who would work within the hospital to implement this system. It was also recommended that it was a public health priority and there would be task groups or steering groups within the community, if you like, to coordinate the whole process. So this graphic just demonstrates some of the how various data streams report kind of the same data, if you like. And at the bottom you can see police data. And if you just took police data on its own, you notice that it's actually increased over approximately, well, this is a 6-year period. It'd be very difficult from that to say that violence in the community was actually increasing. And if you compare that to hospital data at the top, that alludes to the kind of 65% discrepancy, if you like, between what is reported to the police and what is happening. But of course, it's worth noting that just because a violence-related incident presents to ED, that does not mean that all violence-related incidents report to EDs. There would be a large number that present to the ambulance service but don't make it all the way to EDs, and there would be a large number which never present to the emergency services at all. So the Cardiff model illustrates these ways in which EDs can reduce alcohol-related harm during any contact with assault patients. So when a patient presents for an assault, if they have been under the influence of alcohol or the perpetrator of the violence has, that is an opportunity to gain valuable information or to refer that patient to an appropriate service. Similarly, with repeat assault patients, frequent flyers to the ED, it might be that they have a substance or an alcohol problem. It may be that they are being repeatedly assaulted by someone with an alcohol or a substance problem. This data can be shared with the police, and it can also lead to referral to other agencies. If several injured people attend from the same nightclub, this can also be reported to the police, and it can lead to strategic policing, monitoring of that licensed premises, and it can also lead to a licence review, something else I'll come back to. When patients are brought in unconscious, the police can be informed. I was surprised, you might be surprised, this can happen without patient consent, but it can also help police with their work. But generally, the frequency of information sharing with crime reduction partnerships can reduce alcohol-related harm, and these processes all tend to be locally agreed. So this is the evidence of effectiveness for the Cardiff model. It's worth pointing out here that the Cardiff model applies to one hospital and one city, so it's quite useful in terms of tangible outcomes. As you can see here, the solid line is male attendances which are violence related to the hospital, and the dashed line is female attendances, and here we're looking at about an 8-year period, and you can see there's a clear reduction. But just to put that into numbers, since 2002, ED violence related attendances have gone down by 42%, Violence in licensed premises has gone down by 39%, and it's saved at least £5 million a year to health, social and criminal justice costs. Cardiff moved from mid-table within its family of 15 tables to safest city, and this was maintained for a period of time. It also won lots of awards. It was adopted by the UK government and the College of Emergency Medicine and applied across the UK, and it also got international recognition. The Dutch government took it on in Amsterdam, for example. So TIIG, it operates in a very similar way to the Cardiff model, except it deals with systematic data collection across the whole of the northwest of England, which is quite a key difference. It was established in 2001 by the Centre for Public Health, and by 2012 we actually took data from 31 EDs across the northwest. That was all of them. There was only 70 EDs in England and Wales, so we had a fair proportion of the total EDs in England and Wales. We also warehouse ambulance data, which is extremely useful for cross-matching, and we enjoy our third-party status, so we also cross-match our data with other data streams such as police data or other service data. So we have similar key aims to the Cardiff model. We like to monitor trends of both intentional and unintentional injuries. It's worth pointing out here that we only deal with trauma and injury in terms of accidents, road traffic collisions, suicide attempt or assault. We don't deal with the more kind of clinical side. We remove data. We still receive it, but we remove data relating to heart attacks or more clinical conditions. So another key aim is to assist local partners. These might be members of local councils, public health teams, licensing authorities or community safety partnerships. And we inform prevention strategies primarily through the use of needs assessments. So the Cardiff model versus the TIIG model. As I mentioned, it is a city versus a region. So whereas the Cardiff model considers one hospital, we have variable data items across all of our EDs. Not all of the hospitals ask the same questions in the same ways. We also have variable data quality across our different hospitals. That's something we work hard to try and improve all the time. But that point about tangible outcomes is also relevant. Where TIIG spreads across an entire region, the Cardiff model is just one city. So the improvements that they see in Cardiff are much more likely to be due to the prevention and the initiatives that they exact. With TIIG, it's a little bit more difficult. We have lots of cross-patch attendances, and any prevention initiatives, we like to think that we definitely contribute to them, but we can't say definitely that's to do with the work resulting from TIIG data. So another difference is that the Cardiff model focuses on violence, whereas we look at all injuries, including road traffic accidents, deliberate self-harm, falls, for example. One of the advantages we have is that we can compare different areas within the Northwest. We can also generate regional figures which we can compare to national figures. As I mentioned, the disadvantage is we suffer from variable data items, the questions that the patients are asked and the quality. We also have geographical complications that people go into different areas to attend hospitals. Not all incidents happen in an LSOA of residents. So in terms of the alcohol questions that are asked, I've broken down the counties within our region. Cheshire and Merseyside are combined. And this question is whether the patient has consumed alcohol in the 3 hours prior to the incident, whatever that may be. Cheshire and Merseyside, there's 4 out of 10 EDs which ask that question, 5 out of 12 in Greater Manchester, 4 out of 6 in Lancashire, 1 out of 3 in Cumbria. So there's definitely room for improvement. So I'd like to talk a little bit about one of our gold standard hospitals. It's Arrow Park, it's on the Wirral, it's part of Wirral University Teaching Hospital Trust, and it's been sharing ED attendance data with TIIG since 2005. So in terms of, I'll move on to the process of the data collection in a minute, but in terms of what we share as an output, we share assault-related ED data on a monthly basis, and this includes information relating to licensed premises, whether it was a pub or a bar, and also key locations if it happened in a street, for example. We include information relating to weapons used, if there were any, and the relationship of the perpetrator to the victim. We also produce a rolling data file which cumulatively builds the assault attendances into a rolling file, and this includes licensed premises. Where there were more than 3 assaults in a particular place, this gets flagged as a hotspot. In terms of our other outputs, in addition to this routine data sharing, we produce hospital bulletins twice a year, themed reports, and we also offer a data request service which is well used, particularly in Cheshire and Merseyside. So this is a little bit about the process at Arrow Park once patients present at the ED. The data is recorded electronically, and it's also worth noting here, the previous speaker spoke about consent. Now this is implied consent where the patient gives the information over at reception. The patient is not necessarily asked, do you consent to giving this information? Now if the patient group is an assault or a road traffic collision, for example, then a whole series of mandatory boxes will drop down and additional or enhanced data will be collected about that patient. I'll come back to that in a minute. The alcohol consumed 3 hours prior to an incident is mandatory for all injury groups, so every patient is asked that question. The data then goes into a warehouse, is extracted and is sent on to us at the TIIG team. So this is just an example of how we feed back to the hospital in terms of data quality. At the top we've got College of Emergency Medicine recommended questions, and at the bottom we've got questions that we recommend. And it's brilliant that Arrow Park asks all but 2 of those questions, but as you can see there is variable data quality among those questions. Arrow Park, as I said, is a gold standard. It's one of our really best acting hospitals, but there is still room for improvement in some of those fields, and that's something that we work on. It's worth mentioning that the Health and Social Care Information Commission in September 2014 released an information sharing to tackle violence. Most of you probably know this, but it made those top questions mandatory for all EDs in the country to share that data. Now, what's worth noting about that is that the alcohol question is not included in that mandated set of questions, which I found quite surprising. It's one of the most useful questions we ask. So I know this slide's a little bit of overkill, but it's like a look at the broader picture of where that data goes and how it's used. I've already talked through the process within the ED. When it comes to us, we clean and process the data. We make it look pretty before we sharing it with community partners. We also analyse the data for our own purposes, for academic publications, for theme reports, or for data requests that we receive from partners. Once it's shared with partners, typically police, public health teams, the emergency department itself, and community services, it's used in all kinds of ways. As I said before, it's used in strategic policing and licensing. It's used in service provision within a community setting. It's used in terms of prevention initiatives, and it's also fed back to hospital-based services. So at the bottom, I've just highlighted, I was going to draw more lines, but it was just getting too confusing. Lots of these sort of specifics can relate to all of these kind of community-based interventions. So there are hotspots that get considered, particular licensed premises. We can look at environments that are risky, not just in terms of violence or alcohol consumption, but in terms of other injuries. And we look at risk groups. Who's the most likely to get into a fight? Who's the most likely to be drunk? Where will they be? How do we target a prevention initiative? But particularly in terms of alcohol use applies to almost all of these community initiatives. So I've just drawn up some figures here in terms of which patients had consumed alcohol for which patient groups. Now, as you can see at the top, assaults, it's around the 50% mark, and this is looking at 3 years worth of data. Professor Gilmore said about 65% of assaults have alcohol as an associative factor, and that's true. What we're looking at here is where patients have said, yes, I consumed alcohol. There are lots of instances where they might refuse to answer, or they might be unable to answer because they're intoxicated. The questions are all asked at the point of contact, so if they're intoxicated at that point, the data is not usually collected at a later point. As you can see, just a point of interest, self-harm has a particularly high rate of alcohol association as well. And a little bit different to the previous speakers, 6.5% I think it was, all of our injuries at Arrow Park, 8% of them have alcohol associated as a factor. So this is the trend at Arrow Park over the last 3 years, and this is a result of the hard work of not only people within the hospital but the commissioners and the service providers. And as you can see, the assaults have gone down over this time period presenting to the hospital by about 20%. But there are all sorts of caveats to that. For example, the total attendances have gone down by 10%. So really we're looking at the difference there rather than the absolute percentage decrease in assaults. And as I said before, we can't necessarily say that the prevention initiatives that stem from TIIG data are the result of this, but they no doubt contribute. So I'd just like to briefly talk about another case study, and it's the Preston and Chorley emergency departments here in Lancashire. And they are also examples of excellent practice in all sorts of ways. The data process works a little bit differently in Lancashire. There is a central hub called MAID. It's the Multi-Agency Data Exchange, and they oversee the sharing. They're like a middleman between us and community partners. So they link up with community safety partnerships, public health people, and the police. Now, some of the best practice that comes out of Lancs is the constant meeting and feedback that we have not only with commissioners but with the EDs and with community partners. Once every 2 months, we get pretty much everybody concerned with TIIG data around a table, and if there's a problem in any of the EDs, we can kind of thrash it out there and then. In other areas, we meet with an individual hospital, and then we meet with an individual hospital, and it's much more laborious to improve data quality and completeness. Staff compliance is excellent in these hospitals, and patient compliance is excellent in these hospitals. We work closely with the staff. We produce materials that describes what we do. We describe how the information is used, and we produce handouts for the patients. And these typically reassure the patients that the data they give over to the hospital will not be shared with the police. At least it won't be shared with the police with any of their personal details. It will be anonymised, confidential, and they won't get in trouble. There are also some other services at these hospitals that I won't go into just yet. So it's similar to Arrow Park. Here's a breakdown of the data items and the completion rates at these hospitals. There's no point looking at them in detail other than to say that the completion rates for all of these questions that the hospital asks is very good. This is a subset of the data we receive, and it's just the subset relating to violence. So the key thing that I wanted to talk about these, the Lancashire hospitals, Preston and Chorley, is to do with licensing. Community partners have been very quick to act on data that comes out of the TIIG team in order to submit license reviews for premises which are particularly frequent in terms of hospital admissions. So, I mean, initially, our data can lead to targeting policing. It can put the premises on the map and under the spotlight. And then TIIG evidence is used in application reviews. We might give details in terms of the numbers of assaults that have happened there, the weapons that have been used, the demographics relating to the victims, and so on. Now, there's 2 or 3 cases that are ongoing at the moment, and community partners are very optimistic that they'll have positive results. But one review which ended, I think it was the year before last, resulted in an initial closure of the premises and then a conditional reopening, and there were 30 conditions attached to this licence for this particular premises. One of them was that glass was no longer used at the bar. It was all going to be polycarbonate drinking vessels. There was going to be more seating, there was going to be CCTV, there was going to be security on the door. The drinks promotions would be considered because they were harmful and they gave out the wrong message. There would be training for bar staff, and IDs would be checked more rigorously. And just to show you the effect that that had, this is 11/12 to 13/14, and this is data just from that one licensed premises. You can see where the intervention took place, and it more than halved the number of violent incidents we had from that licensed premises. So just briefly on the difficulties and challenges of what we do. As I've mentioned several times, data completeness and quality is imperative. The better data is reported, the truer picture we have of what's actually going on in the community. We have constant problems with IT systems. Almost lots of different hospitals have different IT systems. There's no uniformity and consistency. And feedback loops can always be improved, not just between us and the hospitals, but between the people who are using the data and us. We find it's really useful to tell the hospital how the data is being used, because it not only incentivises the staff at the hospital, it also reduces the flow through the doors, which is the ultimate incentive for people working in an ED. There's also data consistency issues between EDs, particularly relating to alcohol. And also the usefulness of the data is often an issue. A field may be completed to 100%, but if everybody has refused to answer the question, the data is not going to be useful at all. I've mentioned compliance and staff. So just to sum up then, EDs can play a leading and crucial role in reducing alcohol-related harm, particularly related to violence in the community. But we still have quite a lot of work to do in terms of getting all the EDs up to speed. And there are my contact details.